That's exactly what a professional athlete does. They look at their performance and they use all that information so that the next performance, they're just 1/1000th of a second better. That's called cumulative incremental improvements. It's like compound interest. We need to start doing that in medicine. And as we do that, our ability to improve is going to just be like exponential.
Hello, and welcome back for another episode of the Spine Pod. B, we're in San Diego, California.
We got to sit down with Dr. Choll Kim at the XL Spine Center in San Diego, California, and talk about a wealth of knowledge of spine care. It was so exciting to sit down with him today.
Such a wealth of knowledge, so much energy and passion. This is a fun one.
It's incredible to see the work that he's doing, and not just in one area in spine, but bringing the different technologies and procedures and innovations all to one to drive spine care forward. It is so fascinating to look at the practice that he's made here.
I agree. And, you know, he's our first surgeon we've sat down with that's really focused on MIS. So that was really fun to learn about. And something I found super interesting is he said, you know, there's still a lot of patients who don't know what that is or don't fully understand what it means.
I think there's a lot of parallels between what we see in endoscopic spine work and motion preservation, right? It's just behind the curve of what's out there. And so to be able to work on some of that education and the adoption curve and what not only industry knows, but patients know and what's getting out to surgeons, he's driving that on all fronts. And his passion is just palpable, and it's fun to sit down with him.
It absolutely is. So let's jump in.
Let's do it.
Enjoy this one with Dr. Choll Kim.
Dr. Choll Kim, thank you so much for sitting down with us today.
Thank you for having me.
Absolutely. I mean, we can't really be happier to be in a nicer area than San Diego right now. This is gorgeous out here.
We got to drive from LA to San Diego, which was an absolutely gorgeous drive. A girl from Texas where it's a lot of concrete jungle. I'm like, when do I move here? This is amazing.
It's fantastic. It's fantastic. Well, we know you're a busy man, so I want to jump right into it. There's a lot of topics I want to talk about today. And if for anybody that follows your information, they've seen you behind the camera before. So this probably isn't anything new, but
Yikes.
It's a good thing. So you're the director here at the XL Spine Center. You're the founder of Minimally Invasive Spine Centers of Excellence. You're the founder and former president of ESMIS, not a small meeting anymore. World expert in
little baby.
Exactly right. A world expert in laser endoscopic spine surgery. Is there anything that you don't do? Is my question.
I don't do windows.
Exactly right. Well, no, we want to kick off. We want to hear a little bit about what brought you here, a little bit about your background, and really what brought you to medicine in the first place.
Got it. I came to San Diego because I wanted to surf and study biology. So I applied to two schools, UC Santa Barbara and UCSD. And I got into UCSD. So I came down here and I met my wife here. So I have very strong ties to San Diego because now my brother lives here. My wife's family lives here. My mom lives here. And it turns out all my friends from college are my current close buddies. So it's really hard for me to leave here. Even though as a spine surgeon, this is probably one of the worst places to live because we call it the triple tax, the sun tax, the housing tax, and the insurance tax. This is the home of the HMO. So it's very difficult to practice as a spine surgeon here, combined with the fact that because it's nice to live here, it is filled with some excellent spine surgeons. So we're all great friends and colleagues, but you know how spine surgeons are. We're very competitive. So it is brutal out there. But I'm hunkered in and I'm in solo practice, which serves me well because I'm a bit of a control freak. And I went to undergrad at UCSD even. And I've been here for 20-something years in practice, starting out at the university where I was an associate professor by the time I left. And I've been at this practice for 15 years and UCSD just bought this little diamond in the rough hospital up the on the other side of the parking lot. So I'm all the way back to being a UCSD guy, which is a source of great pride for me.
Bringing it full circle.
Yes.
That's so awesome. And it's interesting too, you've jumped around. You don't have a lack of education, that's for sure. UCSD, then you got your PhD at UCLA, correct? And then you decided, I'm going to go to the East Coast for medical school to Harvard, a little known school. And then you made your way back here to UCSD and then your fellowship at Mayo Clinic. But what drew you to spine? Like, why did you jump into spine?
I distinctly remember that. This is like one of my most poignant memories. So as a resident, I scrub into my first case with Dr. Steve Garfin, whom many of us know who he is. He's my mentor. He's the reason why I became a spine surgeon. And he was at the time the chair of orthopedic surgery. And he specializes in complex revision surgery. So the first case was a big, open, posterior revision, multi-level reconstruction. And I looked into that wound and I was shocked. I was thinking, how can somebody survive a surgery of this magnitude? And aside from the fact that Steve Garfin is just the giant in the field and almost everybody looks up to him, I thought to myself, this is an area that I could probably improve upon because there's got to be a better way to do it. So I didn't think I was going to be a spine surgeon. I thought I was going to either be a pediatric surgeon or a joint reconstruction surgeon. But I'm really glad that I had that experience because that led to really the basis of my career, which is to focus on developing minimally invasive techniques to do all the surgeries that we do currently. So that experience really drove me in the direction that I'm in now. And if I ask myself, what would I want my career to look like 30 years ago when I was trying to decide, this is even better than I could have imagined. So sometimes it helps to be lucky and at the right place at the right time and having the right people.
Yeah, a lot of hard work to do that too. Like you said, there's so many other surgeons out here, but you have the success that you have. So that's exciting.
It might be a competitive place for a surgeon, but it's a great place to be a patient, right? I mean, if you're looking for that kind of care, it's a great place to be a patient.
San Diego has a lot of good doctors. I think because it's a great place to live. And if you're not a great doctor, it's hard to make it here. So what's left over are lots of great doctors, not just in spine, but in multiple different specialties. So that's why it's probably really expensive to live here.
Really
and
good
that's the drawback.
That's exactly right. And when you were going through that process, you talked about you were thinking about peds and doing ped surgery. And then you saw spine and you saw an area where you thought you could make it better. Were you looking for that? Were you saying like, I'm looking for something that I want to innovate on? Like, are you a creator? Are you an innovator? Like, what drew you to that? Because if you're looking for easy outcomes and the best outcomes, spine historically has not been the best place to be for that. It's challenging for patient care and everything like that. It has been for a long time. It's getting a lot better now.
That's a very good point. I didn't consciously make that decision, but that is my personality trait. I tend to gravitate toward things that are a bit of a challenge, which is a little pathologic, but that's just the way I'm built. So I'm gravitating toward golf, which anybody that plays golf, I know you play a lot of golf, but golf is one of those games that I'm pretty good at most sports and I can pick it up pretty quickly, like snowboarding and surfing and skateboarding and things like that. Golf it's not like any other activity. And I think spine surgery was the same way. And one of the things that I didn't like about joint reconstruction surgery is that they already had like a huge deal of success. It's still one of the best surgeries you can do. Hip replacements and knee replacements. And so to me, that wasn't that big of a challenge. I could just kind of be a worker bee and do lots of great surgeries, but I didn't feel like I could make an impact on the field and didn't have anything that I can really sink my teeth into to try to work on. That's probably why I gravitated towards spine. That's my assessment retroactively. It's either that or I have a bit of masochism in my blood. But it was one of the best decisions that I ever made because not just me, but almost all spine surgeons, we love our work. You get a few spine surgeons together in the room and you tell them, let's not talk about work, let's talk about something else. And we always end up talking about work. So
the passion,
I'm lucky.
Yeah, absolutely. And I think the passion bleeds strong through the spine community and just looking for alternatives, looking for better options. You're affiliated with a bunch of hospitals down here. You're affiliated with UCSD and Scripps and Sharp. And You've been with other practices as well. I'm curious what led you to starting XL Spine and kind of going off on your own in private practice and doing some of those aspects of it.
That's a good question. Probably the real reason is that I'm a bit of a control freak, and I need to control my environment to a great extent. But I think the practical reason is that my kind of practice and the type of surgery that I do tend to be very different from everybody else's. So I needed a setting where I could focus on doing things that are a little bit different than everybody else without causing a lot of friction in practices. And I just have a very clear way that I like doing things, and it tends to be slightly different than everybody else's. So my previous office is literally right next door.
We walked past it on the way in.
You're right. So it's not a big difference because when I was in that practice, we were like different silos anyway. So when we needed to expand and get more room, it was just a simple decision just to move next door. And this space is perfect for one surgeon like me. So it's a bit of serendipity. I envision in the future that my practice will start to grow. But right now, I'm so happy. I'm the only one here. I don't have to answer to anyone. And I can just make everything the way I want it exactly. And I'm enjoying that part of my career right now.
Absolutely. Well, it's a beautiful center, and you can't go wrong going to San Diego to get care for whether you're local or coming in from the outside.
Right.
And so when you're talking about how your practice has changed a little bit, you did your residency at UCSD and then your fellowship with Mayo Clinic. When you were in the midst of that, did you know you were going to be an MIS or an endoscopic guy, or did you know you wanted to push that avenue forward, or was it seeing patient outcomes? What kind of drove that for you, that interest?
Well, once I decided I wanted to be a spine surgeon, I pretty much decided that, I want to be a really good open surgeon. So I went to the Mayo Clinic, which is just like UCSD. It's a program where they take care of all the craziest cases shipped in from all over the place. And so they tend to be complex, multi-level open surgery with the plan of coming back and starting to develop a minimally invasive program. I just had that in my mind. I didn't know how that was going to happen. And I just know I wanted to do it. So the process was kind of incremental, little by little, adding in this, adding in that, visiting surgeons that are starting to do that, because I'm by no means the pioneer in MIS. The pioneers of MIS are the people that got me to where I was getting to. I'm kind of like the second wave guy that made it a little bit more mainstream and made it a little bit more practical for everyday life. But I had it in my mind that we have to find better ways to do these surgeries, because really the question boiled down to how we're going to get there.
I'm curious for you, over the evolution of your career, if you saw a change in your patients as you really started to focus on that. Were patients asking for it and coming in and looking for that? Or is it something that you had to do a lot of education to patients for them to understand that there was this other option available?
Until recently, most patients didn't know about MIS. Now, with the internet and especially with social media, it's the opposite now. I have patients from all over the country, all over the world coming specifically to see me because they've seen my videos on social media. But before that, I had to explain to them the difference. And I still have to explain that difference to some of my referring providers, other doctors, other physicians. They may even be, orthopedic surgeons that don't really understand the difference between open and minimally invasive surgery. So there's still a lot of educating to do, but the difference is just dramatic. It's not a little bit of a difference. It is like night and day.
I think it's fascinating too, because, and one of the things I really love about a lot of the work that you do and the education and talking towards patients is the concept of preservation, right? Like I would argue, and I'd love to hear your point on this too, that your goal and the reason that you do MIS and endoscopic procedures is for the highest level of physiologic preservation that you can have in the spine. And I'm curious kind of like what your take on that is, and why that's such a big deal, is keeping that natural motion or that natural physiologic function as much as possible when you're talking about these tendons and muscle tissues in the spine.
Well, it's simply because everything is interconnected. You can't do something on one part of the body and not expect the other parts of the body that are right next to it to not be affected. So, unfortunately, lumbar fusions have a lot of positives. My mother has a 2-level lumbar fusion, performed MIS, of course, but it's the least worst option now. But really in the future, we want to try to reproduce what naturally occurs because of that simple reason. There's tissues and structures right next to whatever pathologic area that you're operating on. So if you can avoid a lumbar fusion to treat an arthritic motion segment through, for example, a motion preservation device like a disc replacement device, that is going to be a lot better than a fusion device. We just have to get to that point where we develop the know-how, the technology to make that happen reliably and know exactly which patients to do that in.
Well, that's why I was so excited to sit down with you too, is that convergence of these technologies. And I think that's where we're getting to in spine, is that all these different aspects play a difference in getting to ultimately better patient care at the end of the day. And we've seen this. We have motion preservation devices now. We've had them for a long time. We've had cervical disc. We've had lumbar discs. We now have a set replacement. We have a total lumbar joint replacement that just went through clinical trials, and we're waiting on data to see how that goes as well. But I think, to your point, these things are going to come together to produce better care. And I'm curious what you see as that as well, because some of these are open procedures, right? But in the future, right, everything's going to get better. These things are going to come together, whether it's navigation, whether it's robotics, whether it's endoscopic approaches, and it's going to create this better model of care. But they're going to come together with people like you that's innovating on these aspects.
That's one of the reasons why being a spine surgeon is so exciting, because it's starting to get closer where you can see the light at the end of the tunnel, where a number of different technologies are starting to converge. And just going back to the disc replacement device field, that's been around for about 20 years. When the lumbar disc replacement device first came out, we were worried that 20 years later, we're going to have a sea of catastrophes that we need to deal with in patients that are relatively young. And guess what happened? They're doing great 20 years later. So now with that information, I think the entire field is more excited about taking it to the next level. And things like figuring out a way to put in a disc replacement device, not necessarily from the front, from the back, because going in from the front is not that easy, depending on where you live and whether or not you have access to vascular surgeons. And there's some people that have abdominal problems that preclude that to be done safely. So coming out with disc replacement devices that can be put in through other approaches, either the side or the back. The back is the best because we're the most comfortable going in from the back. And then if we can do that using like all the technology that's already out there, some of which is like in everyday use. So minimal invasive techniques, which have been around for 20 years, that's durable, combined with navigation, which I have in my car, so that now you can put something in exactly where you want it without guessing, without having to rip everything open and look at it with your naked eye. You can look on a map and on a screen like a map and know this is exactly where it's going. This is exactly how big you want it to be. And you can even plan it out ahead of time. All those technologies are converging into one. So I think the next 5 to 10 years is going to be a period of spine where we're going to make some dramatic improvements in the way we take care of patients.
You had this quote in Becker's, actually, when you talked about that exact point of navigation, and you said something along the lines of, we'll look back on, a time now when, like, the fact that we don't have nav and robotics and these technologies in the OR is the same as cars that don't have all of these features that we have, right? Navigation to get anywhere we go. Like, even when I started driving, we had MapQuest, right? Like, I had a printed sheet,
out.
And when I hit a road closed, end of my road, right? I can't get there. But now we have other ways to do that. And that's the same as operating, right?
Yeah, I mean, I've been doing this for 20 years, and on the one hand, I'm just shocked at how long things take to be adopted. But looking back on it, and it's because things don't get adopted like in a line. It gets adopted like a tipping point. So it just smolders along, and then all of a sudden something happens, and the adoption goes through the roof. So we've been noticing that with navigation. So 20 years ago, when I used navigation, almost everyone has said, oh, what a waste of time. Now, I hardly ever talk to anybody that doesn't use navigation for complex lumbar fusion surgery. I mean, it would be weird. You don't need it, but if you want to be the best that you can possibly be, you got to abide by the rules that my mom said. If you don't cheat every once in a while, you ain't tried hard enough. And there's nobody that can beat, all things being equal, putting in an implant perfectly when you have a surgeon with navigation versus a surgeon without. It would be like me competing with another golfer of equal skill, and I have a titanium driver with a graphite shaft, and they're still trying to hit the ball with a persimmon driver. there's no way they can outdrive me. It's not impossible. So taking advantage of technology is huge. And just think about it. We need to put in implants in the spine without injuring the nerve and the blood vessels. That means they're in the way. And if you can kind of magically see through everything, how can that not be helpful? So it just now getting to the point where navigation's accepted, more and more people are exposed to it. And yeah, I think it's going to be very soon that not using navigation will be like having a car without navigation. And do you know, I use navigation just to get to work because I want to know if there's a traffic jam. Not that I don't know how to get there, but I want to know, like, okay, maybe there's an accident and I want to go around this way because why not? I don't want to be late to work just because of a traffic jam. So it's an exciting, exciting time. In some ways, it's silly because almost everything we do in the OR, we've been doing in everyday life, like it's routine. But all of a sudden, you get into the operating room, it's like this little capsule of a time machine environment where things change very, very slowly. And spine surgeons are very resistant to change because sometimes change can be dangerous. And there's a saying in medicine, better is the enemy of good. But the way my brain works is good enough is the enemy of better. So you have to kind of balance our need to stay safe with our need to improve upon things. And we're in a period of time in spine surgery where that part of trying to be better is happening really rapidly. So I'm really excited about where things are going.
Well, we need people like you on the frontier, right? Who are willing to take that safe risk to push standards of care forward. And just hearing you talk, I just keep thinking like it's just building blocks, right? And like we're right at that tipping point. We're really close to being there. But I think navigation and all of these technologies, they're also really exciting from a patient perspective because it makes things possible that weren't 5 or 10 years ago or 20 years ago of different solutions for care that just weren't possible because of the anatomy of the body and the fear of, you know, what you're dealing with if you're going in from the back. I'd love to hear your thoughts on that of just what you see in the future because NAV gives you the ability to do something past just a fusion, which is the current standard of care. But we all know a lot of patients don't want a fusion. They want to continue to have motion. They seek out the ability to get something other than that. So kind of what are your thoughts there of how those intersect and what you see moving forward?
I think two things are going to be really important to make motion preservation devices, like disc replacement devices, safe and effective. The first is applying more and more minimal invasive techniques, and the second is navigation. And those two things separately are well accepted now. We just have to start applying them to motion preservation. And the reason why that's so important is that there's a big difference between doing a fusion and a motion preservation device. When you do a fusion, once the bones fuse, that area of the body, it's done. It's like filling in a cavity. But if you put in a motion device that continues to move, if you have it slightly askew, it's like having a tire that's slightly out of alignment. That tire is going to wear out a lot faster than the other tires. And so in joint replacement surgery in the knee and the hip, they try so hard to get that implant in perfectly because if you don't, it will wear out a lot faster and loosen a lot faster. And its failure curve is much shorter. The same thing's going to be with motion preservation devices in the spine, like especially disc replacement devices. The more precisely and symmetrically you put them in, the more durable and long-lasting they're going to be. This is separate from just pain relief, but you want this sucker to last until you go to heaven when you don't need a motion preservation device anymore. So I think the combination of minimally invasive techniques that preserve the surrounding structures that provide dynamic stability, among other things, and navigation that allows you to better precisely put in the implant exactly where you want it and size it exactly the way you want it is going to make a huge difference in the success of that implant and will make it so that a larger number of surgeons feel comfortable doing that. Because right now, if I needed a lumbar disc replacement, there's just a handful of people that I would want to do it. I wouldn't want just random spine surgeon in town to do it. I would want somebody that just does disc replacement devices to do that surgery because it's that technically demanding. And it shouldn't be like that. The other thing that's great about technology is that just so happens that, our population, we're getting older and more frail, yet we still want to be playing golf. And I'll give you an example. My mom is 88 now, and she still plays golf. We just went to Korea, and she's still there. We walked everywhere, and we sat on a plane for 12 hours. And had she not had her lumbar surgery, she probably would have never done that. And if we didn't have minimally invasive technologies, there's no way an 84-year-old would have a 2-level lumbar fusion. We would tell them to get a nice walker or a motorized wheelchair and adjust your life accordingly. And after her surgery, it was life-changing. She could barely walk. Now she plays golf, she travels, she sits on planes, and she's as feisty as can be. And that extends to everything that we do. As we get better technologically in our skill and our ability to do things more and more, less and less invasively, and more precisely, a greater number of patients that have musculoskeletal problems and spine problems that they have to suffer with because, let's say they're older, they're more frail, or they have other medical problems that would make that surgery too dangerous, now can have that. And it's, diabetes is a terrible thing, but it doesn't necessarily have the day-to-day impact on your life that like a painful spine condition has, or an arthritic joint, because that affects mobility, your ability to interact with people, your ability to do fun things. So it's really important to continue to strive to get better so that we can offer our treatments to a wide array of people, so that we're always focusing on quality of life and trying to optimize every little 1,000th of a second better makes a difference.
Well, I think we'll look back on spine just like we look back on knees and hips, right? Because we used to fuse knees, we used to fuse hips, and people don't remember that, right? Like that actually used to happen. If you look at old radiographs, there's hip fusions, there's knee fusions, and now if you blew out a knee or a hip and you walked in and someone recommended that, and again, I think it's aggregation of all those technologies, right?
Yep.
Not using MIS, not using nav, not using motion preservation devices. All those things are going to come together, but we're going to look back and say, I can't believe we weren't doing that, those aspects. But to your point, the adoption curve is long, right? It's one, like creating the actual devices, right? The instrumentation, the technology, but then two, it's getting the guys like yourself who a lot of them trained on different technologies, didn't have these things, they didn't exist. All they knew was open surgery, all they knew was fusion. And now you have to retrain them, not just their skill set, but their actual mindset towards, what does this mean long-term for a patient?
I mean, you raise a really good point. It's not enough to have great technology. You have to have a mechanism by which you can get that incorporated into everyday practice. And I can just tell you, I often wonder what it is about minimally invasive surgery that makes it so that not everyone does it still. And one of the hugest obstacles to adoption of better technologies is the learning curve. So this is kind of too late, but there was a time when almost everybody owned a PC and only a few people owned a Mac. And during that time, everyone knew the Mac was better, but they didn't want to switch because it's a hassle to learn a new system. But once you learn it, there's no way going back. And now today, I don't really know anyone that doesn't actually have a Mac device in addition to their PCs. And I think the same thing is going to happen. We have to figure out ways to make that learning curve easier, the adoption curve easier. And you know what's funny? We say the same thing in these big scientific meetings among us about the learning curve. We say something like, that's a difficult learning curve. And then the conversation ends there. In every other thing, we ask the next question, which is, what about the learning curve is different? And what could we do to make it easier? And what's the lowest hanging fruit? We hardly ever have that discussion. But I think we need to have that discussion because that's the lowest hanging fruit of adopting new technologies. We have to spend more time and effort understanding what the obstacles to switching over are. Like what makes it difficult to switch? What part of the procedure makes it difficult to learn, and focus on finding ways to get that better. So that's an easy problem to fix. We just have to have the will and desire to do that. And we need a little bit more, momentum and more people talking about it. Because if you think about it, it's probably going to be a much easier problem to solve than designing a whole new implant that works. That's a long-term problem. Addressing learning curve problems, very easy.
I'd love you to say a little bit more about that mindset and kind of like learning curve and things stop. What do you think? Why do you think that's the case in the spine industry? And do you have any suggestions on like how to push that conversation to keep going?
I think there's two things. The first is that humans by nature really resist change. And I'll give you an example. If you go to a country club, let's say where there's golf and tennis, there are people in that country club that have been playing tennis and golf for 20 and 30 years. They play every day and they're enjoying themselves and they're happy. But if you ask them, like, how much better are you at golf and tennis? The vast majority of them have only improved by this much, okay? And then there's the field of professional sports, where that mindset is after every game, after every experience, you're like hounding yourself to try to figure out how you can get tiny bit better. And so I think what's happening in medicine is that, understandably, and by human nature, once you get kind of in the groove and you're good at something and you're comfortable, you just want to keep doing that for a long time. Because it's not a competition right now, is it? Like, as a patient, you have a very difficult time figuring out which surgeon athlete is better than the other, because there's no measure of success that's easy to look at like you would in professional sports. But guess what's changing? The access to information by patients are changing very fast. And in the not too distant future, whether we like it or not, your performance is going to be gradable like a professional athlete's. And I think once that happens, we'll see a dramatic change in surgeons wanting to keep up with the latest and greatest, because now there'll be some kind of pressure to be better, because now there's scrutiny. So it's a scary thing, but it's a freight train coming. And so I tell all my patients, all my colleagues, to keep track of their patients, get outcomes measures, and be like a professional athlete. Go back and look at your outcomes and constantly ask yourself what you can do better. Because if you don't, somebody else is going to tell you what you're doing wrong, and it's going to come down to harming you. So as unpleasant as that message is, that's probably the most important message that I can give to my colleagues that are kind of younger than me, that are looking to me to, like, what should I do to become a successful spine surgeon? It's simply keep track of your results, keep track of your patients, and do a reassessment of your performance like you're a professional athlete.
I actually love that analogy because it's so true, isn't it? You know, it's just like you have someone's life in your hands, and thinking of yourself as an athlete of, like, I should be at my prime, at tip top, be the best, and trying to get just a little bit better every time. That's the surgeon you want, right? That's somebody who has that perspective.
Yep.
For sure.
And for the same reason, I think another thing's going to happen. Like, you know, if you need knee surgery, there's two very distinct types of knee surgeons that you go to. You either go to a joint reconstruction surgeon that does a big open knee replacement, or you go to a sports medicine orthopedic doctor who does all your knee surgery through an endoscope. He puts a Band-Aid on there. It's all done as an outpatient in a surgery center. And I think spine's going to be like that. Someday in the very near future, you're either going to have spine surgery by a reconstruction specialist. You have scoliosis, kyphosis, like terrible spine disease that needs big open surgery with fusions and reconstructions. Or you're going to go to a sports spine surgeon that's going to do minimal invasive surgery. They're going to do surgery a little bit earlier, and they're going to do things that are much more motion preserving, and almost everything otherwise endoscopic. So I envision that there's going to be two types of spine surgeons. One that is like the happy-go-lucky ortho sports surgeons that almost never have to go to the hospital, almost never have to round, do everything in their surgery center, and all their patients are young and healthy and really happy, and they get back to life quickly. Or you're going to be like the intense joint replacement surgeons that still need to do kind of bigger, scarier surgeries, more open. And so as we subspecialize, just like sports, if you're a good basketball player, just stick to basketball. If you're a good football player, just stick to football or baseball. Trying to do both is reserved for the very rare individual that can do both, because most people do much better if they focus on one thing. So I've done exactly that in my practice. I used to do everything. I used to do, complex multi-level revision surgery, as well as minimally invasive endoscopic Band-Aids discectomy surgery. And as I've gotten older, and I don't have like the energy and the wherewithal to do these big, long, huge surgeries and then go to the hospital around before clinic every day, I started focusing on this one surgery, and guess what happened? I became way better at those few surgeries because a lot of it has to do with practice. So the future is going to be, if you have a deformity surgery that needs a big deformity revision reconstruction, you want to go to that deformity surgeon. And it's not just a surgeon, by the way. It's a surgeon and the entire team that is kind of all like fine-tuned to do that whole process well. Or if you have like a little baby disc problem, you go to the minimally invasive outpatient surgeon that just does a lot of disc surgery with an endoscope. And that whole process is optimized to take care of that patient. And so I was saying, in addition to the whole navigation thing, in the not too distant future, the endoscope is going to replace the operating microscope for most simple lumbar surgeries.
It's such an interesting concept. So we've been really lucky that we've been able to sit down with a couple of guys that focus on healthcare economics, a couple of surgeons that focus on healthcare economics. And I see these parallels between endoscopic surgery and motion preservation. And there's this fact that incentives haven't been aligned for that adoption curve. You talk very heavily about this adoption curve, right? And getting people to use these. The truth of the matter is, even if you're doing endoscopic surgery, if you're not instrumenting, you don't have a huge incentive to do that. And you've seen that with motion preservation as well. And then on top of it, there's a learning curve. So you've got like these multiple factors that are keeping people at bay, where it's not an easy adoption of just saying, oh, I'll step in and do this thing. And then the last point you made that I love is the specialization part of it, right? Because endoscopic, I'm sure, just like motion preservation, if you're going to get a disc or a motion preservation or a total joint replacement, you want someone that does 500 of them a year or 300 of them a year. And same with endoscopic, or whether it's an open procedure or a big complex revision surgery, not the guy who does 3 of them, right?
Right.
And I think we're going to start to see more of that in practice as well, of specialization in practice, just like we see in orthopedics, right? Like knees and hips, you want the guy that does 500 of them a year, and that's all he does. And that's exactly what he does. And that's what you're looking for. Yeah. And what you're doing right now, that work is driving that forward, right? Is getting to some of those pieces, starting to specialize. And then you have patients that come to you for that exact reason.
I think that's just going to happen naturally. But you brought up a really challenging piece to all this, and that's the incentives that occur with when you do something, you provide a service, you expect to be compensated for that in a reasonable manner. And I would say that the current state of that whole process, the way like our healthcare insurance and compensation system is arranged, is missing a very important component, which is the outcomes. So it's strange that the way compensation for services is kind of aligned right now is that as long as you do a very difficult surgery, irrespective of the outcome, you're going to be compensated for it according to the level of difficulty. Now, that's fair, but you should also include the outcomes and the results. So if you get a great result, your compensation should be proportionate to that outcome. That's how everything else in this real world works. And because of the way we've set up the way healthcare is delivered, it's not like that. And I think it's just missing that piece. But that's changing too, is my guess. It's going to be difficult. There's going to be a lot of resistance because no one likes the microscope put on them. But it's a freight train coming. It just has to happen. It's unavoidable because it's all about information to access. And just a simple example is just the ratings. After a while, you're going to be able to tell who the bad apples are, because after a while, if you do enough surgery that's not that great, there's going to be enough patients saying so that people are going to start to believe you. And by the same token, if you're doing so many great surgeries, after a while, there's going to be enough people saying that you're great so that you're truly great. And right now, you can game that system a little bit. But once everyone does that, once everyone feels obligated to rate everybody, which is sort of like what Uber does. Do you know, when I get into an Uber, I'm nervous about my own personal Uber score as the Uber passenger. And that's the way it should be. We shouldn't just be able to rate the Uber driver. The Uber driver should be able to rate us. And there's a lot of imperfections with that, but it creates a sense of social responsibility to be the best you can in whatever setting that you are. And that's happening in so many different areas of the world and of our everyday lives that's going to happen with medicine too. So I'm very optimistic that all this technology is overall there's going to be lots of negatives, but overall, it's going to be better for patients and better for everybody.
Well, we talk about this all the time, this concept that I don't think there's anything other than medicine where you can't get objective reviews on what you're going to get done, right? I mean, you go to Amazon, you go to any supplier to buy anything, a car dealership, houses, there's a way to get reviews on who you're working with, what you're going to get for the outcome. Medicine is this black curtain that you don't know anything about. And to your point, there's some practices that are doing it a lot better now with social media. You guys are doing it here. You can get objective views of what's he doing in the OR, what procedures is he using, what do his patients say. A lot of places, there are people that have been operating or outside of surgery, even medicine, you have no idea what their outcomes look like, but it's because it hasn't been pushed. But we're going to see these aspects. And I'm curious too, when you talk about outcomes, do you think we're measuring the right variables right now? Because you talked about quality of life earlier, and I don't think that's as big of a focus right now. It's tough to measure as well, objectively. But I'm curious if we're going to see more of those metrics looking down the road.
Oh, that is a freight train coming. Because just by inherent nature, the person that rates a physician is going to rate them according to their perception of what's important to them. Just like when you rate a restaurant. You're not going to say like, you're not going to talk about the recipe. You're not going to talk about all the components and their distribution of that's pasta sauce. You're going to talk about the experience. So that's just going to happen naturally. And, I use a lot of social media because I think this is the best way to basically communicate with our patients in a broad scale. So for example, when I go to a restaurant, I hardly ever go to a restaurant without first looking at the ratings, looking at the pictures, looking at who the chef is and reading about them, and seeing what some people say about it. And it's not just whether or not they do like 5 stars or 4 stars, it's how they describe their experience. And so as more and more physicians start to do social media, after a certain point, almost everyone else has to do it too. And I hate forcing people to do stuff, but there's some things you just need to force them to do. You need to be able to tell people what you're all about, what you're good at, what you can provide to the person in a transparent way before they show up, especially when you're talking about things that the average person cannot really assess themselves. I'll give you an example. When I take my car into the car mechanic, I feel so vulnerable. They could tell me anything that's wrong with my car, and I would have no idea how to assess whether or not they're being straight with me and whether or not I really need to change the carburetor or whatever. But by looking at the reviews, that helps me a little bit. And as that gets more and more popular, I don't want to go to a car mechanic and feel like totally insecure that they're going to take advantage of me. And I can imagine what it feels like to be a patient. It's like that times 1,000-fold. And so I'm big into empowering people to make truly informed decisions. And the best way to do that is to arm them with as much information as possible.
Well, I think also to that point, patients, because we have all this technology, all this information now available to us, they're starting to demand, because if you are in pain and let's just use fusion for an example. You're like, I don't want a fusion because somebody I know had a bad experience. That happens often. I want something else. You're going to go scour the internet to read everything that you can and learn everything that you can to try to find another solution for yourself. And I think more and more patients are getting more educated. And I don't think as an industry, we're giving them enough credit yet of their ability to really push us in the direction that they want. I think that's coming too. I think that's another building block that's kind of a part of all of this. And I think you're ahead of the curve because you're already out there explaining this to patients, being part of the conversation, which is really important. That makes them feel more safe. But I think that's a big aspect of this too, is patient demand is also driving a lot here.
And it should.
Yeah.
Because we're out there to help patients.
Exactly.
And they're the people that we're trying to help. So they should have a say in what they receive. So that's why I love that you're doing this podcast. That's why I was so excited that you asked me to be on it. Because on the one hand, if we don't do this, then there could be some bad information out there. Yeah. And the best way to overcome bad information is not necessarily to prevent that bad information from getting out there, because that's not that easy. The best way is to provide lots of good information so that people have the ability to kind of sort through everything and make the right decisions. So information is everything.
That we talked about that actually on another podcast. And I think it's really fascinating. It goes into this point too of, you said earlier, there's great things about technology and there's bad things. A lot of information is really great, but it's hard to decipher as a patient what's good information and what's bad information, especially, word of mouth makes most people feel most comfortable to take action. But it's hard as a patient to know the difference between your anatomy and your experience could be completely different than mine. So it's not apples to apples when you're just looking on a forum online or in a Facebook group of what's happened with one patient doesn't mean it's going to mirror exactly. I'm curious if you've had any conversations with patients about that, or if you've experienced any of that, of kind of bad information leaking its way into patients that you speak with.
That happens a lot. So two things happen. Number one, patients make comparisons of themselves to other situations that don't apply to them. And two, they get I'll give you a classic example. I have a lot of patients that are being told by people that minimally invasive surgery and endoscopic surgery is just a gimmick from people that I may know. And they may not say it like that, but that's the way they take it.
Interpreted, yeah.
And it's just strange how that information gets propagated, either directly or indirectly. Public, people in general get skewed views about what's good and what's bad. And then they may equate their problem with somebody else's problem. And the question of how you sort through that's not an easy thing. But you know what I noticed? What patients do is they rely on the credibility of somebody that they look up to. And so what's really important, at least in my social media campaign, is to always put out content that shows that I mean what I say, that you can trust me, and that I'll give you good advice. And I think if you're going to do social media, that's simply all you need to do. You need to kind of show whoever it is that you want to be in front of that you're like a real person that cares about people, and that you're going to do the best, and that you are really good at this and not that great at that, and that you're going to be the type of person that will direct them in the right way. And if you do that, then you can very easily convince somebody that they're acting crazy. So if I say something like, that's crazy talk, and they know me or they've seen me on social media, they respond very differently than somebody that just walks in out the door cold, has no idea who I am, and doesn't really know whether or not they can trust me. So I think the future is that patients are going to derive a lot of their information from credible sources. So that's a lot easier, because after a while, you get to kind of get an idea of who's credible and who's not.
You are so good at promoting educational content across all platforms. You make a lot of video, a lot of educational content. And it's interesting, the point that Courtney just brought up about patients digesting information, there's a learning curve to that as well, right? And how we produce education now and information is different than how we did it 20 years ago, right? And so you're posting where a lot of people are digesting information. YouTube, TikTok, Instagram, that's where people are pulling a lot of things in. And historically, we've done a lot of this research aspect for publications, and patients will pull that. But the problem is, a lot of those are written in such a mechanical way that it's tough to pull out what the paper is actually saying. And I think we've seen, when we talk about adoption curves, we've seen problems on both the patient side and the surgeon side. And it's for the reason of there's old information out there, right? So you talk about MIS and endoscopic being gimmicky, right? I think motion preservation has seen the same thing. You go back 20 years, there's tons of data, but if you pull a research report from Charité from 20 years ago, you talk about all these explants and all these problems, but that's not how it happens anymore, right?
Yeah, until recently, we didn't have a means to communicate with a large segment of the population in a kind of easy way. So you guys are too young to remember this, but like the way we reached a large number of people in the past is through radio and TV. Now, if I wanted to make a TV commercial right now, I wouldn't even begin to know how to do it, and I would not spend the money to do that. But that was the only way back then. Today, I can make a 60-second video on my iPhone, post it for free, and if it's meaningful content, it would be seen by many, many people. So that's why I've really embraced social media because, I've been trying to get the message out that MIS is real, it is effective, and there's a group of patients that would benefit from it. And now for the first time, I can get it out there very quickly. Whereas before, it was really slow. I had to give presentations at scientific meetings. I have to get in front of like other referring, like primary care doctors, like a few at a time. Now it can be almost instantaneous. So I think the issue of educating the public is going to be less of a barrier. What's going to be the biggest barrier is making sure that we do this in a responsible, credible, responsible way. And I don't think that's going to even be that difficult. There's always going to be that fringe group that is just on the fringe. But the middle of the bell curve, I think, is going to be filled with lots of good information that I think patients are going to benefit from.
So we've talked about the evolution of adoption and education for some of these pieces. You've been in practice a long enough time now. I'm curious specifically to motion preservation. How have you seen that change over time and throughout the course of your practice? And what are you excited about with motion preservation devices moving forward?
One of my favorite surgeries is a cervical disc replacement. But what's the most awesome thing right now is the lumbar motion preservation kind of landscape. So 20 years ago, the lumbar disc replacement device came out. It looks like a knee replacement device that's circular. It goes in from the front and it treats the bad disc. But that's it. Turns out in the spine, a motion segment, a joint, is not just the disc, but there's two little facet joints in the back. And so the disc replacement devices back then didn't treat the facet problems. In fact, if you had facet problems, you didn't want to put in a lumbar disc replacement device. You would instead get a fusion. But it would be nice to treat both. So now, recently, there's facet replacement devices that are turning out to work really well. And now there's a motion preservation device that can treat both a bad disc and the facet joints. So I'm a big believer in customizing care. And knowing that we want to preserve function, preserve motion, and we want to customize care, it's so great that now you can see a patient and decide, is it just the disc problem? And do they just need a disc replacement? Is it just a facet joint problem? Do they just need a facet joint replacement? Or do they have both? And do we need to do a replacement of both the disc and the facet joints? So now all of a sudden, there's very little reason for 1 and 2 level problems to need a fusion, because all the other things that we used as an excuse to do fusions are kind of no longer valid. So I think in the very near future, we're going to see a lot more motion preservation, a lot less fusions for simple 1 and 2 level problems of everyday people that have really severe back pain that's affecting their function and quality of life that understandably do not want to have a fusion procedure.
I think, obviously we feel excited about that too, because Modus is the first lumbar total joint replacement. It's finishing out the data collection phase of an FDA trial. So, we'll see in the next 2 years where that goes. But our hope is that it's going to be commercial and be able to use that. I think a lot of patients don't realize that there's the facet joints in the back, and that can often be where a lot of the pain comes from. Can you kind of talk about, the different areas of the spine where you can have issues and maybe, barriers we've had in the past with motion because we haven't been able to treat every single aspect or replace every single aspect of the spine?
Because most people have both disc and facet joint problems. So it turns out even less people just have facet joint problems without disc problems. And that's why Modus is so exciting. It's exciting on a number of different fronts for me, but it's probably going to be most applicable to the majority of people that have back pain, because most people have back pain because both the disc and the facet joints are painful because they're interrelated and interlocked. So for the first time, we have something that kind of solves everything in terms of the pathologic areas. But the other thing that's great about the Modus device is that, especially for me, it can be put in minimally invasively just because of its design. So number one, it can be put in from the back, and surgery from the posterior approach is way more comfortable. It's like the bread and butter approach that all spine surgeons need to be excellent at. And then the way it's designed is two separate parts. You can be put in minimally invasively, and it would almost exactly mimic the procedure that my mom had for a fusion. She had an MIS TLIF. It's a fusion procedure where you make two separate little incisions instead of one big incision in the middle, because a lot of the work is done through those two little corridors. And for some reason, we decided making midline incision and exposing both those corridors at the same time was a good idea. And it probably was at the beginning, but it's entirely unnecessary because the middle is just in the way, and turns out it is where the multifidus muscle is. So if you can come in from two separate incisions just outside the multifidus muscle, you maintain the integrity of that middle part of it. You don't have to stretch tissues all the way out unnecessarily. You can just make a long, narrow corridor and do everything that you need to do through what we call a perimedian approach. And that is the workhorse of posterior MIS surgery, the perimedian Wiltse-like approach. And when you do that compared to a midline approach, the difference is dramatic. And so I envision when that implant comes out, I will want to put it in minimally invasively. Mm-hmm. And I bet you it'll be easier to put in minimally invasively, especially with navigation. So I anticipate that's going to be a dynamite strategy to take care of a lot of our patients with like arthritic back pain.
That's why I get so fascinated coming down here. We went from an open approach to now we have MIS and endoscopic. We had fusion for a long, long time, and now we have motion preservation devices. And if you ask people back then what they want, you don't know what you want until that technology is there. And that's why I get so fascinated when I come down here, because that was the first thought that I had. As I was like, we have a posterior approach device that is now hopefully coming on the market very soon, has data collection and all those other aspects. But you could put that through an MIS tube. That's converging the two aspects. But you don't know that you want that or need that thing until it's created, right? And then the things merge together and you create this new alternative, this new value driver down the road for patients.
Well, and I think it speaks back to what we were talking about earlier of you have to have surgeons who are willing to be on the forefront to say, oh, I believe in minimally invasive surgery. And then you have someone like, Craig Humphreys and Scott Hodges who are like, I want an alternative to fusion. We have to find something. And you take those two together and you say, this is the magic right there, like them doing that and finding that it's exciting and pushing motion. And you're like, patients deserve more minimally invasive. Let's get them up quicker. The magic happens when you bring those together. So you seeing that and saying, I know how to bring that to the next level because of my skill set. Like, I think that's really exciting right now for patients because that moves us forward.
That's exactly why when people ask me when you're going to retire, I just look at them and go, why would I even think about retiring? This is the best time that I can remember to be a spine surgeon. And I just look at other specialties. I'm biased because I'm a spine surgeon, but I can't imagine being in any other specialty right now because of exactly what you said. A lot of it is timing. It's the perfect time where multiple different technologies are converging and all at the same time, information transfer ability, the ability to get the message out, to quickly find out what's good and what's bad is also converging in there. So I think the future of spine care is going to be vastly different 5 to 10 years from now for all those reasons all coming together that I don't think anybody really predicted.
When you're looking at MIS procedures, what you're trying to solve for is preserving as much of that natural function and the natural tissue as you can. I think motion preservation is doing the same thing in spine, right? I mean,
it's an extension of that, right?
Let's look at the problems that we're dealing with right now. PJK, huge problem, right? ASD, huge problem. And we see that because we lock up the spine. We know when we go from sit to stand, we can put the spine in a posture alignment when you're standing. The problem is we sit 10 hours a day, right? You don't because you're operating every day, but everybody else, right? We sit all day long. Like we're not working. Not as many people are working out, in the fields and doing manual labor. And if you are, even more so, you need to be able to move through planes, right? And do some of these aspects. And we can talk, this is a concept that I love that you talk about too, is this quality of life function. Because the truth of the matter is, to your point, if you go get a fusion done and it's done by a good doctor and the surgeon's done well, you're going to get a big pain reduction, especially immediately post-operatively. Now, we see problems that happen down the road, right? That could be 10 years down the road. But if you're 30 years old or 40 years old, we're seeing more and more of those things occur. And we have to look at these long-term outcomes.
Yep. And I think the thing that I see for the future is that we try to move away from being like, a one-tool carpenter and try to expand our toolbox with the ultimate goal of really customizing care to each individual patient, taking into account their individual pathologies, their goals, and customizing everything. And that requires not only looking at their lifestyle, including diet, exercise, and fitness, because that's really, really important. I actually spend most of my time telling patients to just be healthier, and like a minority of my time talking about surgery. But what we want is to have, instead of trying to fuse everybody with back pain, we want to be able to be much more precise. Like, the back pain is due to this. They want to get back to that. And, they have all these other things. So what's the best customized option? And the best way to do that is to employ technology and have an array of choices so that you can find the best treatment for that particular patient. Trying to fit everybody into one or two categories, that's where we get into trouble, especially at the peripheries of patients that if you can do something else besides a lumbar fusion, you should do that. If they need a lumbar fusion, then you do it with the most advanced technology, most minimally invasive strategy possible. And if you need to reconstruct their motion segment, to decide what's the magnitude of the surgery, how many structures do we need to replace, and having choices allows us to basically pick exactly what's best for that patient. And if you do that, how can you not get better results? It's just common sense. So this is the first time in a long time where we just have a wide array of treatment options for our spine patients. And the next 5 to 10 years is going to be really awesome.
I agree. It's not one size fits all, right?
Nope.
And so this is why we're here, and being able to share this information with patients and see there is one, it's really exciting to, what's coming for patients, because that's what it's all about. But two, it's just fun to be in the industry too, like you said, and see this is really, the standard of care is shifting, and we're in a really exciting place to say, being able to look at patients and say, there's better things coming for you as an individual.
That's true.
I love your concept too of this customized care model. And I think data aggregation and data collection is going to play such a big role in that as well. When you look at outcomes data, you look at, radiographic data, and merging these aspects, we're no longer going to go in guessing what device should be put in, right? We're going to know what surgery for each person.
That is such an important point. The outcomes information and data, that's similarly another technology that's converging, because analyzing the data of 10,000 patients is not that big of a deal anymore. And just literally 10 years ago, a study with 100 patients was a big deal. Now, if you can gather data on every patient that you operate on, you can very quickly get large amounts of data. And now we have the technological capabilities to analyze that data. And things like AI, which is a fancy term for just much better computing power, can take lots of different information and crunch it so that it generates useful information. And as that occurs, not only will we be able to figure out how to put in implants the best, but we can confirm that that's the right thing to do. And based on the results, you can keep fine-tuning it. That's exactly what a professional athlete does. Mm-hmm. They look at their performance, and they use all that information so that the next performance, they're just 1/1000th of a second better. That's called cumulative incremental improvements. It's like compound interest. We need to start doing that in medicine. And as we do that, our ability to improve is going to just be exponential.
I'm going to steal that concept because I love that. No, seriously, right? Because if you looked from today to a week from now, you don't see a change, right? Even if you're making these small incremental differences, but in a year, and 3 years, and 5 years, huge differences, right? That goes for surgeons, that goes for patient outcomes as well. In these small incremental differences, you could say, well, we did it for a month and we didn't see anything. Yeah, but it's a month, right? What does it look like in a year, or 3 years, or 5 years? Because that's exactly what's going to happen. We're going to have these small incremental changes that drives care forward. And you've worked on, those registry side of things, because that's a huge component of it, is actually setting up the structure that can collect the data to make that happen.
Yep.
It's such a big component of it. But One thing I do want to ask, and you have your own center here, and you've built your practice over this time. What are you excited about the next wave of spine? Whether it's research that you're working on or surgical outcomes, what gets you to not retire and want to continue to keep working and working with patients and doing that every single day?
That is a difficult question to answer because there's so many layers to that. The first is continuing to apply all the technologies that we use every day so that we increase our toolbox and customize care to patients. But you know what one of the biggest challenges for me is? Educating my patients, answering their questions, and making them feel like they can make a good decision. And so I don't know if you're probably not aware, and most people think I'm crazy, but I give out my cell phone number to all my patients because I want them to be able to ask me questions. But they hardly ever call. And it's probably because they don't want to bother me. So as scary as AI is, I envision the following. So right now I have like PAs and assistants that kind of mimic the answers that I give all the time. So imagine in the not too distant future, you can call and you'll talk to my AI. It looks like me and it basically pulls all the information that I tell it to pull, probably all of the internet, but also listen to everything I say, everything I write, everything I record, every operative report that I've ever written, every clinic note that I've ever written, and use that as your database, in addition to like Medline and all the information that's out there on publications. And now you can call and you can ask me as many questions as you want, any time of day, 7 days a week, 24 hours a day, 365 days a year. I will never get irritated. I'll never get impatient. It could be at 3 a.m, and I'll just answer the same question asked in slightly different ways over and over again without any irritation. And it will allow me to focus on the key things that only I can do and make it so that all the things that just seem redundant and silly to me, but that's really important to patients, are readily available to them, because my favorite patient is the one that has tons of information, that has done tons of research, and is really knowledgeable. My least favorite patient is the one that says, I don't know, you tell me what to do. Because for some reason, those patients don't do well. And I think it's because it's really difficult to like, it's not like buying a car. Most everybody can do an analysis on Consumer Reports and decide which features of a car that they like. It's very difficult to do that in medicine because it's much higher level of technicality. But once we have the ability to communicate with patients and educate them, my life was going to be so much easier. So that's the other layer. Not only being technically better, but being more available to my patients somehow and using technology to do that.
It sounds exciting and also really scary
I
at the
know.
same time.
It's like being at the top of a double black diamond run. You look down, you're petrified, but you're also like stoked. That's what AI is like for me.
I think patients not having, you not getting calls from patients is a good thing. If your phone's blowing up,
true.
it's probably a big problem, right? I mean, it's not that you don't have a busy practice here, but you bring up a really good point. And truthfully, this is something that I think is really good for patients to know. What questions should patients be asking when they're coming in, especially when you look at specialization, right? On like, what procedures are available, or like how should they be going about getting that care? Because this is the reason we're sitting down here, right? It's really tough to figure out what you should be doing in spine care and what should they be asking for and who should they be looking for.
I'll boil it down to one question. You look the surgeon deep into their eyes and you just simply say, what would you do if I were you or I was your beloved family member? And they can't look away or blink or hesitate. I do the same thing when I ask, should I have the steak or the seafood? You should ask that question. In addition to the multitude of other questions that you're just going to come with, always ask that question. What would you do if you were me?
And
insist upon, and don't blink. Don't look away. Just force them to give you an answer.
But I mean, it's true. It's what it is, right? I mean, that's ultimately what we get down to at the end of the day. And it's like, I think it comes with all the aspects that we're talking about, right? When there's more objective reviews and outcomes and data and this information, like there will be, and I think that we're starting to see it, but accountability on all fronts on, not just operation, patient walks out the door, but what is that patient doing in 2 years or 5 years or 10 years down the road? And I think that's even going to go towards outcomes collection as well, right? We've done a lot of focus on pain reduction or pain scores, ODI, NDI, things like that. I think we're going to see more functional outcome metrics as well, right? And we've seen more wearables data collection and things of that nature. I think we'll see more of those as well, of what are patients doing, to your point, when you do an endoscopic surgery, what are they doing a day after surgery that they aren't doing with a different procedure, right? Because I think that's really important.
I'm glad you brought that up.
I think it's important.
That's hugely important. And one of the other things that I'm really excited about with healthcare in general that's related to big data is that like I go to my doctor every 6 months to a year. They draw my blood. They compare my results to this general average at that one time on that day that I had my blood drawn. But really, the better way to do it is continuous monitoring. And the averages and the deviations are related to my variations. And now imagine you can correlate that with my energy level, my mood. And so you can work on being fit rather than not sick. So, because the US, we're excellent in sick care. If you get really sick, this is where you want to go. Where we really are weak at is health care or wellness care. So the future is a wearable that is continuously monitoring a variety of things that at the same time can monitor your energy level, your activity. And if you also can measure your mood, then it can kind of fine-tune all these values and capture problems well before it happens. And I'll give you an example. I'm a little scared about, talking about this on social media, so maybe you may not want to put it on there. But 8 years ago, I had a life-changing experience. 9 years ago, I thought I was absolutely indestructible. I never got sick. I could stay up all night. I could do 12, 15-hour surgeries, and then I could run faster and hit the ball longer than a lot of my younger colleagues. Then 8 years ago, I got diagnosed with colon cancer. And boom, my life changed. It's 8 years ago, so I'm really lucky because I didn't really take care of myself that well. In fact, it was discovered through a colonoscopy that I got at age 52, and I'm sure you're supposed to get it at age 50. And now it's probably 45. But if I had that colonoscopy at age 50, I could have just had like a little polyp snipped. Instead, I had a bowel resection, I had chemotherapy, and for 5 years, I was petrified that I was going to have a recurrence. And I still have like some residual symptoms of the chemotherapy. So finding things early and treating diseases early on in the disease cycle is so much better than waiting until you're sick. So the most exciting thing that I look forward to in medicine is that we're going to be much better at identifying disease states well before they become sick states, and that will make healthcare much better. It will, like I'm getting older, so I want to live a long time. You can't decide you want to live a long time when you're old. You want to decide you want to live a long time when you're young, sort of like taking care of your car. You want to keep it maintained regularly. You can't be racing around, flooring it all the time, and then later decide you're going to take care of it. So the most exciting thing about healthcare that I see is that there's just going to naturally be more focus on wellness rather than sickness and quality of life.
Do you think we're going to see that same thing in spine care? So to your point, I think colon cancer is a huge one, because right now it was like, oh, well, you can wait till 60, 55, 50. And now it's slowly backing down because there's really not a downside to checking that early, right? And you're going to catch things earlier instead of having it turn into a huge problem, solving something at the point of care versus retrospectively going back and treating sick patients. I think we're seeing that same thing in spine right now, right? Yep. There's a reason we're doing endoscopic care. There's a reason we're doing motion preservation operations or non-instrumented operations, is because it's funny that this is kind of your tagline, but less is more, right? Like less is absolutely more, because we can always do more, but why not? If we could treat something 10 years earlier and either put it off or reduce the chance of a complication happening long-term, I think we're going to see that same thing in spine.
I am certain of it because I'll give you an example. If you have discogenic low back pain, you have an arthritic spine, usually the story is like this. When it gets bad enough, come back and we'll do a fusion. So two things happen. One, you suffer for a long time until you're ready to make that huge massive step to have a relatively large operation that's scary. And by that point, the disease state has progressed a lot more. So if we have the ability to do treatments earlier, that's got to be better. Now, I don't want to overgeneralize, but it's always better to start with something smaller and escalate up if you need to. And guess what happens? You generally don't need to escalate up. It's very infrequent. But if you don't have any of those treatment options early on, you just end up doing a lot more of that bad treatment earlier because a lot of people can't wait. So I think spine care is no different than anything else. Earlier is better for the most part.
Well, whether it's preserving natural tissue or the motion of the actual segment, it's the same concept, right? You're preserving that to reduce the effect of long-term complications down the road. And I'm not sure if there's another specialty that we look at like we look at spine or have looked at spine for a long, long time where people say exactly what you just said of do whatever you can to put off surgery as long as possible. I'm not sure if there's another care model that says that of like, you have a brain tumor, just wait as long as you possibly can. I mean, seriously, that's an extreme example, but isn't it interesting that that happens?
Yeah. It is strange.
It shows that there is space for improvement. There's space for innovation. So we're going to do it, you know?
Yep.
Well, I think we've seen that happen too, right? I mean, we went from, open procedures to endoscopic and MIS. We've gone from fusion and to your point is great as well. Fusion is always going to exist, right? I mean, we're going to aggregate the data, and in some small instances, that's going to be the case. You want a stable joint, and to reduce, get a big decompression and get a stable joint, you're going to want to do that. And in other cases, hopefully the majority, we restore motion just like we do in knees and hips and shoulders. But both those are a continuum over time, right? And now all the technologies and the education is coming together because even if you had all these technologies on the table, I think if you didn't have some of the education materials that we did going direct to consumer like we're seeing, I'm not sure what the adoption curve would look like. It might be another 10 or 15 years before some of these things get out. I mean, how long have you been talking about it just to get this concept and you still get it? Well, this is gimmicky. It's like, no, there's plenty of data and research supporting it. Motion preservation is the same way. 20 years of research, it's there, it's ready. Yep. And we still have to continue.
The decision can't just be left to one party. It has to be all the parties participating in that decision making. And that means that all the parties need to be empowered with the information that's necessary to make the best possible decision. I'll leave you with one last disturbing observation. We do a lot of lumbar fusions. It's a bread and butter surgery. It's very common. So you think that there'll be a sea of spine surgeons who've had lumbar fusions on themselves or their immediate family members. And I bet you're not going to even be able to think of more than 2 or 3. And you've probably know a lot of spine surgeons just like I do. That's a disturbing observation. It's very uncommonly performed on ourselves, yet we recommend that a lot. So we have to face that reality. If it's not good enough for yourself, it's not good enough for your patients either. So that's going to drive things as well in the direction that it's supposed to go in, because in the end, you want to customize the care and you want to do unto others as you would want them to do unto you.
Yeah.
It sounds really simple, right? But it goes back to the point that you talked about. Like, that's the conversation you have across the table of like, what would you do if this was your brother or your mom or your daughter? Like, what would you want to have happen? When you're having those discussions with patients, are you setting, are they setting goal parameters? Because that should be a discussion prior to surgery, right? Like, what are you trying to get back to? Because somebody that's a marathon runner is going to be a lot different than, an 80-year-old who says, hey, I want to do X, Y, Z, or I want to play golf. Those are different conversations. How are you setting the stage, or what does that discussion look like prior to surgery?
A lot of that discussion is basically getting to know the patient and then asking yourself, honestly, if I was this patient, what would I do? And so I often run late in clinic, and my colleagues will see 50 patients a day, maybe 70. I see 20 to 25, and I have 2 PAs helping me. Because if I can't get to that answer, if I can't ask myself, what would I do if I were you? And I don't know, I just can't move forward. I'm just built that way. So, and I tell patients, there are many cases where I just look at them and I go, I need to think about this. I don't know what I recommend. I need to think about it some more. And whether or not I need to call them back or just mull it over my subconscious, I find myself doing that a lot. And I hope all my colleagues do that, but it's not what we're taught. What we're taught is to think very scientifically. Well, in reality, we should think about it scientifically, but just as much on a personal level. And that one simple question cuts through everything in my mind. That question always makes it so that I feel like I can sleep at night and that there's no possible way I can do any better for this patient. I do that same thing in the OR. Every question is, what would I do if this was me or my family member? And I rely on that a lot.
The way that you're pushing the spine care, just spine care as a whole forward, it doesn't happen without people that are willing to pick up the flag and push it forward. You said other people have pioneered endoscopic care. Well, someone has to pick up that torch and move it forward, right? And I think you're doing that through education. You know, the thing that I want to wrap on, you have over 100 million views on YouTube. You've got over 30 million views on TikTok. You have over 6,000 followers on Instagram and LinkedIn. Where can people find you? For people that are looking for you, where can people find you, or where should they go to find your information?
I just go to Google and type in my name and find the parts that appeal to you most. But I have a website. I have social media platforms. I have a really awesome staff that answers the phone. In my office, a humanoid must answer the phone in 1 or 2 rings. Because same thing, I cannot stand calling somebody or an office and getting that phone tree. Press 1 for this, press 2 for that. I called my pharmacy and they literally made me go through 5 things before I got to talk to a human being. Because if it's automatable, I'll be on the app and do it. But if it can't do it on the app, just let me talk to a human.
Mm-hmm.
Well, that's amazing. We appreciate your time so much. We know you're a busy man. You got a bunch of other things going on today. So thank you so much for hosting us here. Absolutely fantastic practice. We really appreciate it.
Thank you for having me.
Thank you.
Well, hopefully we'll be
Thank
back
you.
soon and we'll continue to watch everything that you're doing. So
I hope so.
awesome. Thank you so much.